welcome back to Rural Health for You and Everybody. I'm here with Dr. Snow, one of our rural health clinic providers here at Maury County Medical Center, and we're here to talk about Colorectal Cancer Awareness Month, colonoscopies at MCMC, and that sort of thing. Welcome, Dr. Snow.
Thanks. I'm Dr. Stephen Snow. I'm the Chief Medical Officer here, actually, at Maury County Medical Center as well. I more or less have been here for about 7 years, although I was had about a 1-year hiatus in there where I was actually a hospitalist down in Mississippi. So thanks for inviting me.
For sure. Glad to have you. So as you know, March is Colorectal Cancer Awareness Month. So kind of just to get a bit into it here, can you tell us why these diagnostic and preventative screenings to detect colon cancer are important?
Yes, thank you. There's actually a couple reasons why they're important. First of all, colorectal cancer, it's kind of changed a little bit, but it's still the third leading cause of cancer death in both men and women in the United States. And we actually... unlike some other cancers, we kind of know the natural history of colorectal cancer. The only caveat to saying that is rectal cancer is actually a little bit different than colon cancer in terms of how you treat it, but it's basically what part of the colon that's involved. The natural history of colorectal cancer is that they arise from something called adenomatous colonic polyps. Adenomatous colonic polyps vary in size. They start as a small polyp, and generally that's defined as less than 8 millimeters in size, which is about 1/3 of an inch. And then they progress to larger polyps, which are greater than or equal to 8 millimeters in size, and then to something called dysplasia, which means they contain abnormal cells, but they haven't quite turned into cancer yet. And then eventually proceed to colon cancer. And on average, that takes about 10 years. The other part of that is most colon cancers, although there are some syndromes like ulcerative colitis and Crohn's disease and something called familial polyposis syndrome, something called Lynch syndrome, which increase your risk of cancer. 70% of cancers are still sporadic, meaning there's not some family history otherwise that would increase your risk of colorectal cancer. That's why we recommend screening for both men and women of all ages. It's estimated that about 30% of men will have adenomatous colonic polyp in their lifetime, and 20% of women will in their lifetime.
And when the guidance kind of changes a lot, when is the guidance for getting those kind of screenings?
Yeah, that's a good question. So there's kind of a history of doing colonoscopies as well. Back when I was a resident and then first out of practice, and as my wife would say, 100 years ago, but actually it's not 100 years ago. It was actually about 32 years ago. We used to do screening sigmoidoscopies, and then a sigmoidoscopy is just kind of the first, about 1/3 of a colonoscopy. Just that first part after the rectum, the first part of the colon is called the sigmoid colon. And and what we did is if we found polyps, we sent them then for a colonoscopy to remove the polyps. What we found out then is that we were doing a real good job of keeping people from getting colon cancer in their sigmoid colon, but they were getting more cancers in the other part of their colon. And so about the mid-90s, we switched the screening from sigmoidoscopy to colonoscopy. And during that time frame from about 1998, 1999 to the present, for all age groups, except the youngest age group, colon cancer death rates have gone down. The other part of that, though, is data in the last couple of years shows that if you look at, now that's death rate, this is actually incidence of colorectal cancer, so this is anybody getting cancer. It showed that between 2000 and 2013 that colorectal cancer incidence actually decreased, except for people between the ages of 45 and 50, and it actually went up 13%. And so patients that get cancer before the age of 50 really tend to present a little differently. They tend to present more symptomatically. And but because of that data, we moved the age of colon cancer screening back to age 45 because of that data. And the other question is always, well, when do you stop doing them? It's generally recommended you do these between the ages of 45 and 75. The other nice thing about moving it back to 45 is the math lines up. When it was 50 to 75, you do one at 50, and then 60 and 70, and then probably not at 80. But 45, 55, 65, 75 actually lines up pretty good. It is recommended. That brings up to how if you do it. Well, if you don't have any polyps on the first one, you generally do it 10 years later. And 10 years is the magic number because of what we talked about, that progression in polyps that takes place over the course of about 10 years. Above age 75, the reason why that's kind of the cutoff is starting at age 75. Colonoscopy is actually a very safe procedure. Risk is about 1 in 2,000 to 1 in 5,000, so depending on your age. But as you get over the age of 75, and certainly over the age of 80, your risks of having a complication of colonoscopy starts to go up, and your benefit starts to go down, only because you have less of a life expectancy at that point, and taking out polyps at, say, 85 isn't going to really probably change your life expectancy at all. So.
For sure. And you talked briefly about kind of those patients presenting symptomatically. Are polyps the only symptom that may arise with this kind of cancer, or? No,
with colorectal cancer, symptoms you might have would be bleeding and blood in the stool. Most of the time with polyps or early cancer, that's actually occult blood, meaning that you don't actually see blood in your stool, but you would have blood in the stool as what we call a stool occult blood test. If it's these tend to form a what we call an apple core lesion, so they kind of grow this way around the colon, and if it gets tight enough, it causes an obstruction, and then you would get pain and symptoms from that. If it goes through the wall of the colon, it'll irritate the nerve endings and cause pain as well. Weight loss can be a sign of any kind of cancer, actually. So those are the main symptoms of colorectal cancer.
Sure.
But of course, what we're trying to do with screening is not get those and get it before that happens.
For sure. So maybe kind of those early symptoms, that might be the first indication that someone should go see their primary care physician and then see what their recommendations might be from there?
Yes, if you're having symptoms like that, if you're having blood in your stool, it's interesting, especially in that 45 to 50 age group, or even sometimes younger. We used to say, well, the most common cause of blood in your stool is hemorrhoids. Actually, that's still probably true. But the second most common cause is actually colon cancer. So it's really important to if you're having symptoms like that to go see your primary care doctor and get referred for, in that case, a diagnostic colonoscopy. And of course, I keep going back to it because this is not a cancer you need to have. So it's better to go in for your routine physical, let's say, and you're now 45 years of age, and go get your screening colonoscopy. And there are some other methods of screening out there. There's checking the stool for occult blood. There's also the Cologuard test. Cologuard and people that do colonoscopies are a little bit in competition with each other, if you would. If you want to think about it that way. How I think about Cologuard is I would rather have somebody do Cologuard than nothing for their screening. What I always tell patients about Cologuard is it does have a certain amount of false positive rates. It has a small false negative rate also, but false positives aren't a big deal, except that then you have to have a colonoscopy if it's positive. And most of the time when it's positive, people have polyps, and then you have to follow them up with colonoscopy, a certain interval, sort of, and that's a whole nother area that has actually changed a little bit in terms of follow-up. But in general, if you have polyps, you do a sooner follow-up than 10 years. So
for sure.
Yeah.
And kind of, I guess, if you have any suggestions or advice that people may take away from this that could either help them improve their overall colon health,
Correct, yeah.
Stuff like that.
There are a number of risk factors, and actually an important one is that if you have a first-degree relative, I'm going to talk a little bit about risk factors and also things that can reduce your risk, kind of in the same discussion here. If you have a first-degree relative, which means like, mother, father, brother, sister, that have had either polyps or colon cancer itself, you want to start screening at age 40 or 10 years before that person had their polyps or colon cancer, whichever is earliest. So in other words, if you had say your father had colon cancer at age 55, you'd want to start your screening at 40. If your father had colon cancer at age 45, you'd want to start screening at 35. So 40 or 10 years, whichever is younger. And we already kind of mentioned ulcerative colitis and Crohn's disease. They don't immediately increase your risk, but after you've had the disease for about 8 years or so, it starts to increase your risk of colon cancer. So those patients actually need to be screened fairly regularly. Obviously, age, race in general. We already mentioned that men are a little bit higher risk than women. About 30% versus 20% with polyps. Afro Americans have a higher risk of colon cancer than other groups. Obesity, diabetes, eating lots of red and processed meat increases your risk. Smoking is a big one we think about smoking and lung cancer, but smoking actually increases your bladder cancer risk and also your colon cancer risk. And alcohol consumption probably increases your cancer risk as well. In terms of protective factors, it's all the good stuff you're supposed to do. Like physical activity, a diet high in fibers, fruits and vegetables, high fiber diet. There's some question about eating resistant starch, but that has sort of had some mixed results. So I won't go into that a whole lot. Folic acid, probably reduces risk of colorectal cancer. Vitamin B6, calcium and dairy products do. Vitamin D does as well. But, taking vitamin D, especially around here in the wintertime, is good for your bones, but it's also good for your colon. Making sure you got enough magnesium in your diet. Garlic has been shown to reduce risk a little bit as well. Coffee, actually, a nice cup of coffee a couple times, one or two cups a day.
Everybody's day
seems to reduce colon cancer risk. And then there are some studies, with aspirin and non-steroidals like ibuprofen and things like that, naproxen, Anaprox, things like that. They reduce your colon cancer risk, but they probably increase your risk of other things like ulcers and things like that. So overall, it's probably not. I wouldn't necessarily. It's not recommended to start taking aspirin a day to reduce your colon cancer risk. I mean, it does, but again, it's a risk-benefit thing. So
for sure.
Yeah.
And why would you say that people should schedule their colonoscopies here as opposed to some other healthcare facility?
Yeah, well, that's a very good question. I mean, first of all, when I do colonoscopies here, I tend to schedule 3 to 4 of them on whatever day we happen to be doing them, and so I think that gives us the time to really do a good colonoscopy, as opposed to. And I'm not suggesting anybody around here does this, but if you have a high volume center, you're a little bit more likely to want to get the patient in and out. As fast as possible. I mean, we try to schedule them, an hour apart so that we have, plenty of time to do the colonoscopies. In fact, there's kind of a quality measure with colonoscopy, which is how long you spend. A couple things: how long you spend coming out. Because usually we, on the way in, not to get into all the specifics, but on the way in, they really don't care how long that takes. It's more important, and we on the way out, because that's when we really look for polyps, and you want to look at all the little crevices and everything and make sure there's no polyps in there. And I want you to spend at least 7 minutes or more on the way out. I mean, most of the time we're in a 10 to 15, depending longer if there's 10 polyps we have to remove, of course. They really want you also to find, approximately 20 to 30% of your patients should have polyps based on, the data I gave earlier. So if you're not having that percentage, then maybe you're not looking close enough. So, I think that's an important part of it. We also have, a really good team that works together. We do all ours with what we call MAC, or monitored anesthesia care, which uses medicine called propofol, which really, even though there's lots of, you might remember Michael Jackson and his propofol, but propofol is actually in this setting a really nice medication because it has a quick onset. It really has a quick offset, and you really don't have any discomfort or feel anything with the exam. So I often tell people probably the worst part of colonoscopy is the prep, because the colonoscopy is actually pretty comfortable because you don't that works fairly well. We got a great anesthesia team here that does that, and you don't. And the other big thing is I mentioned the prep. So the prep makes everything cleaned out, right?
Very true.
Exactly. So when you're still finishing up your prep, it's certainly nice to drive across town to do your colonoscopy, than all the way to, say, Sioux Falls and do your colonoscopy, and maybe having to stop a couple times because you're still working on the results of your prep. So that's another, I think, point of doing it locally. So.
And you got a little bit into the prep, but how can people better prepare for their colonoscopy? What can they expect, either regarding the prep, regarding anything, the scheduling process, that sort of thing? Any insight you can share? Yeah,
so, scheduling is just if you see your primary care provider. Sometimes that's actually me as well. But they'll actually, with our new Epic system, it'll actually bring up right in your chart that, hey, this person's due for their colonoscopy, their screening colonoscopy, and then during that visit they put in a case request and make sure the person's okay for that MAC protocol, but it's not general anesthesia, so it's actually fairly low risk that way. So. But at the same time, it works really well, like I talked about. Like I said, the worst part is probably the prep, and it's just because you got to get everything out of there so that I can see, look for polyps, basically. There's a number of preps we use. One is the standard Go Lightly prep, which is a certain amount of salts and things with water. The big jugs, that you've heard about, and basically what the salts in there do is it keeps you from absorbing that water, and then it cleans everything out. There's something called a movie prep, MOVI, which has methylcellulose in it, which is what's in Miralax essentially. That can come as a kit. You also can just get Miralax and mix it with Gatorade and kind of do the same thing, except not the red grade Gatorade because that changes the color of the colon and it makes it harder to do. But blue and yellow and green work fine. And you just mix some Miralax in there, and again that doesn't absorb, so then that sort of cleans it out. I mean, the only thing I'd say about that Miralax prep is you really need to really follow, you know, the guidelines that it has in there, because that one's a little less effective. You know, I can't stress, I guess, the importance of having a good prep, because if you do a colonoscopy and you can't see half the colon because there's stuff left in there, you know, you're only getting half of a colonoscopy, because I can't, you know, guarantee there's not a polyp, you know, if there's, you know, if it's occluded by stuff, so to speak, okay? We'll just call it stuff, okay? And you know, it's so that's why it's, like I said, the worst part, but probably the most important part of the prep for the colonoscopy. So otherwise, the only other thing is if you're taking a blood thinner, we usually have you, if it's like aspirin, we have you hold that for a week before taking it. If it's something like Plavix or Brilinta, we have you hold that for a week before. Coumadin, we usually hold that for 5 days. Some of the other ones like Eliquis, is you only have to really stop that for 2 days. Xarelto for about 3 days. So that's why, you know, sort of at the visit with your primary care, they can look at all that and say, you know, make sure you can, you know, stop those for 7 days. For instance, if someone had a stent last month, what they need to do is wait a year and then do their screening colonoscopy, because they really shouldn't be off the, you know, like the Plavix and aspirin for the first year after a stent. And it is a screening test, so if you're not having symptoms, you can just postpone it for a year. So
for sure.
Yep.
And anything else to add before we wrap up for today?
That's probably the long and short of it. I guess the only other thing I'd add is just we sort of, I guess another good news is we've sort of changed a little bit, and it'd probably be a whole nother half an hour discussing all the ins and outs of that. That's kind of for me to worry about more so than the patient. But you know, if you do have polyps, they have changed the follow-up times of the colonoscopy a little bit, made it a little bit longer than we used to. And we used to say, oh, you need to do one every 2-3 years. You know, a lot of people can probably go, if you have polyps, you're probably going to wind up doing a colonoscopy in general in somewhere between 3 and 5 years, with maybe a little bit more emphasis on you can probably go 5 years instead of having to come in 2-3 years. So.
Sounds good. Well,
right.
Thank you for joining us, Dr. Snow. And if you would like to make an appointment at the Rural Health Clinic, you can call 507-836-6153. That's 507-836-6153.